This is a patient who is presenting for pelvic pain and is seeing or saw our gynecologist for evaluation of endometriosis. So patient is or had hysterectomy. So this is post-hysterectomy. And let me, if there's anything that kind of jumps out to you, feel free to chime in. But this was super
What is that
subtle
nodular thickening in vagina?
vagina. Okay, let's go back to the vagina.
Axial.
Axial, excuse me. Okay, axial.
The other way.
Here.
No,
Okay,
the
the other way. Down, like,
down. Yeah.
okay.
Yeah, that one.
Oh, I think it's just gas because we put
Okay.
gel. Yeah, great question. Okay, so does
I
she,
have a question. Are the
yeah.
ovaries like really high up? Like, did they tack them up?
Let's see where the ovaries are. So there's one here,
No,
and
the
there's
other
one
ones.
here.
That extra
Okay,
soft tissue around the ovary, left ovary.
left ovary, soft
Yeah,
tissue like here.
yeah.
What about it? I think it looks okay. But let me see. What are you thinking about
That's
here?
T2 dark. So is that again an endometrial deposit?
Oh, maybe. Let me pull it up. I wanted to show you the bowel DIE. Where's the T1 fat at?
That leftover is filled with like T1 hyperintense stuff.
Yeah, here it is. Yeah, there it is. Yeah. So there's an endometrioma, or maybe or hemorrhagic cyst. Here, this one. This T1 bright.
Yeah, it's not shading that a ton.
No, it's not shading. It's very kind of like T1 bright, T2 bright, excuse me. Oh, so okay. So I just wanted to direct you. So there's here plaque. So and this was like 6 centimeters worth of like deep endo, and they had to do like a segmental resection. It only measured like 3, maybe 4 centimeters, but when in the OR, like when they stretch it out and stuff, I think it always kind of becomes a little bit longer than what we see on MR. But there was like deep endo involving the sigmoid. So I think it's really important just, comb through the rectum, the sigmoid, very closely and very slowly. And they're typically like dark like this. And they often cause distortion. So here, for example, it's kind of invading into the wall. So then you lose that normal fold of the sigmoid. So just,
I know you've
it's
talked about just like describing how circumferential it is. I find
Mhm.
it like, what would you have said here? Like it's just on that back wall. So
Yeah.
that's why
So
they could do segmental.
yes, here, maybe this is better. I just break it into 4 quadrants, since this is probably 30% circumferential invasion. So if it's more than 50%, then they completely, like they do like if it's less than 50%, then they can shave it. They could do a primary, they just cut it out and then just re-anastomose it, uh, reoppose the wall. But if it's more than 50%, then they have to do a complete resection of that segment.
On this image here, I find it hard to see the edges of this thing. Where would
It's right here.
Oh, I see. Just that dark thing
The
back.
dark thing, yeah. And that's what they all look like. It's dark, T2 dark like this, right? And it's subtly different, but it's different
Yeah.
from the normal colonic sigmoid wall here. I mean, it's easy, and sigmoid is hard to detect sometimes, because it's a little bit more floppy, because it's sigmoid mesentery. But if you are careful and you can see them. I mean, rectum is nice because it's more, fixed, so it's easier to see it compared to sigmoid. So this was a sigmoid deposit, but it's on MR. Yeah,
Nice.
right here.
Two things which they mentioned about endometriosis that savvy, especially about the rectum. We talk about mushroom cap all the time. They said like MR, as of now, like no modality is sensitive enough to tell that is that just at the surface, at the serosal surface, or is it invading? So that we don't know. And it's only histopath Once the segment comes out after resection, we know. Second thing, which was more practical and I liked it, not every T1 hyperintense focus in a female pelvis is endometriosis. It has to be judged in the clinical context. Maybe what if she has had just recent, like some trauma, or just like at the end of each cycle, there is ovulation. So is that T1 brightness subtle here and there? Is it actually endometriosis or not? That has to be like weighed with caution.
Kind of like Nelly has also emphasized that not every T2 dark band is deep infiltrating endometriosis. It could just be scarring. I think they showed that at SABI too.
Yeah.
Yeah.
Yes.
Together with their clinical symptoms. I'm sure here maybe sigmoidoscopy helped.
No, we didn't do a sigmoidoscopy.
Oh, okay. So, but like you said that it was penetrating, probably transmural, like involving all layers.
I don't describe the depth of invasion
Got it.
because it's really hard to like say how deep it invades. So instead, we describe the circumference and then the total length, craniocaudal length. If the length is more than 3 centimeters, it's too long, and so then in those cases they do a segmental resection. If it's a short segment, then they can just shave it off. Or yeah.
Got it.
Okay, so I have this 50-something-year-old man, and here's what we see on CT. So what do you guys see?
Lots of fatty masses. Are they from the kidneys? No, not from the kidneys.
No,
So
I
they're
think it's
from
adrenal
the
glands.
adrenals. So either like myelolipomas or congenital adrenal hyperplasia. And actually, there's a case from the cookie jar with like massive fat containing. Oh, actually,
We had that. Where's that one your fellow presented?
Exactly.
Heart.
Yeah. It was just
Heart
like
tumors.
this. And they were actually myelolipomas in the setting of congenital adrenal hyperplasia. So you not only get hyperplasia, but you also get myelomatous hyperplasia.
That is exactly what it is.
Yeah, there's
Oh yeah, there's your
testicular.
adrenal rests.
Yeah, testicular adrenal rest.
So the reason I'm showing this case is twofold. One is definitely the association between testicular adrenal rests and adrenal myelolipomas. One is like, I definitely wanted to talk about the imaging appearance. They're usually bilateral and they're near the mediastinum of the testes. So that's a very good clue to identifying them. And even more important, for this patient, they did biopsy of the testicular lesions like at least 12 or 13 years back, but then they did not say it was adrenal rest tumors. They said it was probably Leydig cell hyperplasia or tumors. And I'll tell you the reason. So I found this article, I found this in one of the pathology textbooks, and it says that Leydig cell tumors can mimic histologically congenital adrenal hyperplasia, and there's no way to know unless we know it clinically. And then they also talk about this thing that Leydig cell tumors are unilateral. If you can, sorry, read that. So Leydig cell tumors are unilateral versus congenital adrenal rests are multifocal and bilateral. Like as like Dr. Sekhar was with us in December, and she said pathology may not be always the final answer. Like if you give CBD versus choledochal cyst to pathologists, they'll say CBD like biliary epithelium. So similarly, in this case also, pathology may not be the final answer. And don't be surprised if you get histopath as saying Leydig cell hyperplasia or Leydig cell tumor when you're suspecting or anticipating adrenal rest tumors in the testes.
Cool. I'm a little confused because so the adrenal cells are mimicking Leydig cells, or they're both kind of the end result is a sort of like hyperplasia of the Leydig cells.
No. So it looks like Leydig cell hyperplasia on regular histopath, like regular H&E slide, but it's not the same cell.
Oh, interesting. And by the way, is this one of those WHO pathology books, like the ones you can just buy on Amazon?
This is Mills and Sternberg's Diagnostic Surgical Pathology.
Oh, okay. Because I really like those WHO books, so I was excited to have somebody else who.
I think this is actually one of the good books because one of my pathology friends from India recommended it, and this has most of what we like. So
Cool. I love it. And so he's 51, so it's very unusual because my understanding is that congenital adrenal hyperplasia is a spectrum.
yes,
And if it's like you're on the severe end of the spectrum, you get salt wasting and the baby is suffering. So they usually treat it, like catch it and treat it very early. Whereas your patient and also my patient must be on the more mild end of the spectrum. So it got to this point where they got all this hyperplasia.
yes.
Got it. Cool. Okay.
Wow, that's a big mass.
Yep. So there's a mass here. So where do you think it's coming from? And what do you
There's
think?
pancreatic
Pancreas.
ductal.
Yeah. So there's a little bit
It's
of
going in and out. So there's like a pancreatitis, autoimmune pancreatitis aspect to it.
yeah, exactly.
I remember you telling me that river that flows in and out.
Yeah, the Guadiana River in Spain that
Yeah.
Dr. Joseph would talk
And
about.
that's what I'm seeing right now.
Yeah, exactly. So you see little faint bits of the duct, it comes in and out. And then the duct is not, dilated to the proportion that you would think it would for like a real normal mass. And especially not an adenocarcinoma, which wouldn't really get this big. And the other cool, interesting thing is that this is the patient 2 months prior that their pancreas was normal.
Oh, wow.
Yeah. And I should have looked this up, but it turns out they have, and I'll just for completeness, I'll show you the PET where now on 2 months later, that all of that stuff. So they actually have they have a bad esophageal cancer.
Yeah.
And then they have this, and this was actually this is IgG4 related autoimmune pancreatitis, and it's thought to have been induced by the immunotherapy that the patient is on for their
Oh,
esophagus.
wow.
Yeah.
I
So,
didn't know you can induce it.
oh yeah. It can
Oh.
be related to different like chemotherapies and immunotherapies and stuff.
Oh.
Mhm. Yeah, especially the immunotherapies because you're like, you're altering the immune system, right? So an autoimmune disease would be is a possibility.
Yeah, that makes sense.
Yeah. So, okay.
My turn?
Yes.
Okay.
Immune checkpoint inhibitors like nivolumab, drugs like these can induce the IgG4 related disease.
Okay. You're going to have to give us a very practical and succinct summary of immune checkpoint inhibitors versus immunotherapy, et cetera, next time.
Sure.
Okay.
Okay. So this is the patient with a suspicious prostate lesion, Pirates 4. It's right here. Here's the diffusion. And it restricts, it was biopsy proven. I think it was grade group 2 or 3, 2, I think. Anyways, I'm showing this case because of how the patient was treated. So any guesses as to what is happening right here?
That some kind of like radiation bulb in the urethra.
So this is an ice ball.
Oh, cryoablation.
Yeah.
Wow.
So it's a transperineal needle, and you saw that the prostate cancer was very central, and then so I have images, actually intraoperative images, where you see the ice ball gets bigger and bigger and bigger. Yeah.
Someone was just asking me for where people do transperineal ablations because we have a patient who doesn't have a rectum, like they had an APR.
Oh, okay. Yeah, we do them. Well, Rochester does them. Yeah.
Oh, cool. That's
Yeah.
good to know.
Yeah. Yeah, we do. But we do transperineal biopsies here.
Okay.
Yeah.
And do you know why the cryoablation is transperineal versus transrectal? Or does it not? You don't know.
I don't know, but it's a much safer approach.
Okay.
because the rectum is, you can like injure the rectum, right? You don't have a length here.
Mm-hmm.
Like you would have to have this, and yeah. So I think a lot of the procedures now they do transperineally because it's safer, and there's also a risk of, bacterial translocation and stuff like that when you get the rectum.
Yeah. Very cool. And do you know, they must be able to do fusion then because we do like MR ultrasound fusion biopsies. So they must be doing some kind of fusion.
Yes. So this was done by our radiologist, Woodruff, who's like an interventional abdominal radiologist. The transperineal biopsy is done by our urologist, and they do it fusion, and it's transperineal.
Hmm. And do they do all their biopsies transperineal?
Majority of the
Oh, wow.
biopsies are now done transperineally.
Very cool. It makes a
It
lot of sense
requires,
because it's like right there, right at the base of the perineum. So it's not that far to go, and you can just like go straight into it rather than through the rectum.
yes, and it's I think that again the other thing is complications with sepsis,
Mm-hmm.
urosepsis, and just reducing risk of complications. And some suggest that you get better localization and detection for anterior lesions and like high base lesions.
Mm-hmm. Cool.
So then we got a follow-up imaging several months later. This is post-contrast, but it was like the tumor was completely dead and it was non-viable. So this was the area, and then the previously seen like diffusion restriction had completely normalized here, and then the DCE showed like complete. Before there was asymmetric enhancement of that area. But then post-treatment, I mean, on follow-up, it resolved. Sorry, it's a little bit slow. So, but yeah, so it did great. So the patient's going to just continue surveillance imaging.
Nice.
So this patient comes with history of trauma. And what do we see?
The history of what?
Trauma.
Trauma. Okay.
So we see some foci of active blush here. And there is some widening of the pubic symphysis. Couple of hours later, he scanned again.
I was
And
gonna say this is like high risk for a urethral or bladder injury.
Mhm.
Do you have a sagittal?
I saw a
You might be able to see it.
higher up too.
1 second.
Although that's from the active extract too.
Oh, wow. Oh, it's big hematoma.
This might even be what they call like the high riding bladder. Like it's
Mhm.
getting pushed up a little bit. So it's
Yeah,
like, I'm
yeah.
concerned about the urethra.
And there's something in the prostate too. Is it just like Peyronie's, the calcification?
I think that's more like calcification of the prostate.
Yeah.
Yeah, that's not bleed. This is bleed.
Yeah.
So a couple of hours later after stabilization, he scanned again. And I'm showing this image after a couple of hours, same day. So we see that the distance between the pubic symphysis, these two bones, is slightly decreased and looks more stabilized. The hematoma is bigger, but then there's no active bleed now. So basically not a procedure, basically something was done to stabilize his pelvis. And the answer is this.
Oh, like did they belt him up?
Yes. So this is actually a pelvic binder, and let me show you on. So it looks like a belt, but they stabilize if there is like pelvic fractures or injuries.
Wow, that's cool. I've never seen that. So how long does that stay on?
That's a good question. I don't know how long do they put it.
Mm. And it looks like they didn't go to IR or anything for that bleed.
No.
Interesting. They must have just thought like, okay, maybe it'll tamponade itself off. We'll get a follow-up scan.
Yeah. So this buckle, probably the belt looks like the regular belt. It's just the buckle which is slightly different.
That 3D rendition is so cool.
I feel
Yeah.
like, didn't you just show, I think you showed us something, a penile clamp, and then I showed a Cunningham clamp.
Cunningham clamp, yeah.
Yeah. I feel like you're getting really good at these external things that we don't really need a CT scan for.
You can do a review article on external objects.
On things that should be found on physical exam.
Or maybe like, uncommon things with uncommon devices. Like you had one in
By the
the
way, there is what is going on in the penis that the hyperdensity right there.
Peronis.
Oh, that was already there.
Yeah.
Okay, sorry. I thought you were talking about the prostate earlier. Got it. Very cool.
pancreatic pseudocyst. No.
Okay, here's the pancreas.
Wow. Ooh, look at that.
So it's
Oh
a
my gosh.
cystic and
Where's it coming
solid
from?
mass. And another clue is this is a male
The
patient.
man. Mhm.
It's not an ovarian mass, and it's kind of higher up than you'd expect for an ovarian mass. And the one key thing is like, is it retroperitoneal or peritoneal? So all of the retroperitoneal structures, including the vessels, seem to be pushed back.
Displaced,
So
yeah.
it's a little bit more like mesenteric rather than these guys being pushed up. So mesenteric based or peritoneal mass with cystic and solid components. I do have an MRI, but do you have any other thoughts now currently?
Has the patient had trauma before?
Nope. Why?
No, I mean, like, could it be like a sequelae of like a prior
Oh, like an ancient hematoma?
hematoma or
I had one
something?
huge, enormous thing called an ancient hematoma, which is like a hematoma that keeps expanding over time because it has like friable vessels in it.
Oh,
That's not what this is.
okay. I mean, I'm thinking some kind of primary peritoneal process. Um,
Okay, here is the MRI. I'm not sure it adds like a ton, and we've got a lot of
septa, yeah.
effect because
Is
it's
it enhancing the solid,
uh-huh.
the
So
right?
cystic, and then this solid part is like T2 bright over here, and then I'll show you the enhancement, and I'll
Does
also
it restrict also? Oh
Mhm.
yeah, it does enhance, yeah.
So there's the enhancement, and then I'll show you the diffusion. So it's restricting, and this is the
Restricting,
ADC.
but
But I
not
will say
a lot, like lymphoma restricting.
exactly. So it is restricting, but not a ton.
Yeah.
So what do you guys think?
And I mean um hmm, some kind of mucinous. No, it could be, I don't know.
The other thing that caught my eye here was like, is there peritoneal disease? If you look at this fat up here,
Yeah, a little bit
there's a little
strandy. Or it could just be like edema, like just from
exactly. So not sure.
mass effect.
Okay, so you said, what did you say so far? Some kind
Um, yeah, I mean, I don't, I'm not, I can't like zoom
Serous or
into.
mucinous marker in males, like primary peritoneal or primary mesenteric. Is that a
yeah.
possibility?
So you can rarely get primary mesenteric mucinous cystic neoplasms and of the retroperitoneum more, and again, more commonly in females. So it would be rare to have it in a male. So that's a good thought. Another thing we think about when we see massive tumors in the abdomen is a gist. Although this looks weird for a gist, they can be solid and cystic, but usually they have central necrosis. And so do you want me to just tell you what this is?
Yeah,
Well, first of all, ChatGPT, we put in
got it. Yeah.
solid and cystic mass in a middle-aged male, and they said gist as number one, and this
Wow.
correct diagnosis is number two, and it was desmoid tumor.
Wow.
Yeah.
Really?
We said large, very large cystic and solid mass. Yes. And I think okay, so I'm going to talk about a few things. So first of all, when you say large mesenteric mass, desmoid could and should be in there. Another interesting point in retrospect is like, this is very homogeneous, the solid part, right? So even when like that enhancement, it doesn't really look like a typical kind of sarcoma with like heterogeneous enhancement, necrosis. It looks more bland, almost of like the lymphoma kind of blandness, right? But lymphoma usually doesn't have the cystic part and usually has more restricted diffusion. So anyway, this solid part is all fibrotic. The person who showed this to me asked me then, but like, isn't this T2 very unusual because it's not dark if like for desmoid fibromatosis? And that's a really important point here is that on MRI, desmoids can either be dark if they have more of the collagenous component, or they can be really bright if they have more of the spindle cell component. So do not get fooled. Even if it's T2 bright, like brighter than muscle, it can still be desmoid fibromatosis because it has more of the spindle cell component. And when they did a percutaneous biopsy of this, it came back spindle cell neoplasm. So we still thought, but they did say like possibly fibromatosis, and then this was resected and it was fibromatosis. That stuff in the left upper quadrant was not peritoneal disease. It was just like edema. And the other thing is desmoids can be cystic. More rarely, but they can be cystic. So a few other points about desmoids. They're usually in 20 to 40-year-olds, 2-to-1 female to male ratio, so more common in females, more common in patients with Gardner's and FAP. Typical locations include the abdominal wall, the mesentery, and the retroperitoneum. And the fibromatosis that we see in the abdomen is the one that we call desmoid, but it's it's the same thing as the aggressive fibromatosis of the extremities. They are very they can be locally aggressive and can recur. Some of the treatments, especially for the abdominal wall ones, is watchful waiting. And then after that, possibly resection, especially if it's causing a bowel obstruction. Although, like I said, they recur a lot, so they don't like to resect them. And then they can use things like tamoxifen and radiation as like a last ditch kind of thing. So yeah, it was just a huge desmoid tumor that was cystic and solid with this Oh, one more thing. Actually, I found a paper about imaging of desmoids, and they said that there was one paper that looked at their DWI, and they do not have as dark of ADC as more malignant tumors, like sarcomas and stuff. So that's a little bit of a clue that this could be a desmoid.
What a great case.
Yeah, and ChatGPT got it, number 2.
I have a case of the ChatGPT also got right. I've already shared it, but I can share it again as a companion.
Sure.
Okay. I had already presented this case to you all, but another ChatGPT.
Let's see if we remember it. Oh, I remember you showing this, but I don't remember what the diagnosis is. The 2 dark things.
Yes, that's exactly right. So they're symmetric at the level of the Bartholin gland bilaterally.
Wait, is it Bartholin gland hyperplasia?
Yes. So I put the description and ChatGPT gave me a differential, and it could be endometriosis, it could be Bartholin gland hyperplasia, it could be blah blah blah, and then it was resected, and that's what it was. It was nodular hyperplasia of the Bartholin gland bilaterally. Amazing.
Yeah. In our reading room, it actually led to this big discussion because somebody said like, oh, every ChatGPT query takes up costs a gallon of water for climate change.
Is it? No, really?
Right. No, but then listen to this. So then my colleague goes, only a gallon? Every hamburger is 600 gallons of water. One hamburger. What? Yes. So the meat industry, and specifically the beef industry, is like one of the worst contributors to climate change. But anyway,
all my gosh,
all the grass, like everything you need to like maintain the cow, and then also all the methane, I don't know, all that stuff is equivalent to 600 gallons of water for one hamburger. I looked it up.
I heard like one almond is takes up like 15 gallons of water.
Yep.
Just get one almond.
Yeah, it's crazy.
That's incredible. And now with the massive water shortage here in the Southwest, you
I know.
think again,
so I was feeling a little bad about using ChatGPT, but now I just feel bad about eating meat.
I think we can make a lot more impact by eating less meat than ChatGPT. ChatGPT is more good to us than meat.
Yep. Okay. non-contrast CT. We're in the pelvis.
Is that hematoma, hemorrhage?
There's something in the pelvis.
Yes, nice. So there's
Yeah.
hyperdense peritoneal fluid, so hemoperitoneum. And then there's something here, right? That's like cystic and dark and whatever.
Yeah.
So I'm going to show you an MRI that will show this much, much better. But just to show you how limited non-contrast CT can be, this is our
Rupture?
MRI.
Oh, wow.
Yeah. So now you can see that it's separate from the uterus, and it's this large, gnarly looking solid mass. And you can actually see the follicles of the ovary next to it. So we can see that it's in the ovary. It's in the left ovary because the right ovary is over here and the left ovary is here with all the follicles pushed to the side. And it looks pretty solid and it's enhancing and it's got central necrosis. So this looks really different than that desmoid I just showed in that it looks really aggressive and kind of, you know, like this is actual necrosis, not so difference between cystic and solid and actually solid with necrosis, right? Anyway, so any thoughts on what this could be? Solid, aggressive looking mass based in the ovary.
I'm sorry, can you show me the T2 again? It's intermediate, right?
Yeah. Well, yeah, I mean, it's a little bright slash like, sorry, I don't know what all these measurements are, but
Like, I mean, germ cell, like tumors.
yeah, good. So basically either some kind of primary.
And not, yeah, not like the coma spectrum because the signal is intermediate and not so
Excellent, excellent,
dark.
excellent. So 60 to 70% of ovarian tumors are going to be like the cystic epithelial neoplasms, like serous and mucinous. Another 20% are going to be like hold on, I had the Radiopedia article up before I misspeak about any of this. Okay, another 20% are going to be germ cell tumors like teratomas, dermoids, yolk sac tumors, choriocarcinoma. Another 10% are going to be fibrothecomas, thecoma, sertoli Leydig cell tumors. And so when we think about cystic masses, usually that's the epithelial ones, and then solid masses, especially if they're really dark, like dark as a muscle, we think about the fibrothecoma spectrum. So it's a little bit unusual to have like a really solid malignant primary ovarian neoplasm. But anyway, this was resected and this was actually a melanoma metastasis.
Oh, wow.
Yeah, this patient actually had a melanoma.
I wanted to say
There-
Met now. Yeah.
Yep. Yeah.
But
So that's actually like one of the points of what I would like. Melanoma to the ovary is pretty rare, but whenever we see a solid lesion in the ovary, even if it's unilateral, we should think about MET.
did they have already known diagnosis of melanoma?
They did, but it was like of their upper extremity or something, and this was their only site of MET.
Oh, wow.
Yeah. So a couple of points about melanoma to the ovary. So generally metastases to the ovary is not uncommon. And we think about gastric, pancreatic, and also lung, and breast. The other like melanoma is pretty rare, but it can go to the ovary, and actually people with very aggressive metastatic melanoma, like it's often found in the ovary, like on autopsy, for example, they have a poor prognosis, they have a poor 5-year survival. So this was, an aggressive solitary met to the ovary, but, is not a great prognostic feature. So,
Melanoma and RCC, right? Those are the some of the malignancies that can go anywhere.
yeah, yep. Yep. I always like for melanoma when I'm doing like a follow-up check, liver is really a big one, especially for uveal, like ocular melanoma. But I always do like an extra check through like the muscles, soft tissues, small bowel, and then like the classic kind of unusual places are like spleen and gallbladder, but also ovary. So
Can I add two things to that?
yeah.
I mean, one thing which you had shown a couple of months back when we were showing bilateral mets to ovary, and we did discuss that there was a paper from Cookie saying that only signet ring cell tumors are Krukenberg. Not every mets to ovary is Krukenberg. Of
Yes,
course,
and I don't think that's from Cookie. I think it's from Malak Atani from Malincrot. It was a paper in AJR.
Yes.
And it was called it was discussing about Kirkenberg. Yes. Continue.
And the other thing is nowadays they say that all the ovarian cancers are like the bulk of ovarian cancers, which we called epithelial tumors, including serous, mucinous, Brenner, endometrioid, and all, they are actually coming from fallopian tube. So fallopian tube is the primary, and ovary actually is a secondary site of metastasis. That's called STIC, which is serous tubal intraepithelial carcinoma.
Yes, correct. You know what's interesting? I got the same takeaway from that. Kate Maturin gave a great talk about that at SAR one year, about those stick cells. My impression was a little bit different, which is that a lot of the aggressive ovarian tumors that actually cause mortality and are these actual aggressive fallopian tumors called stick that come from the stick cells. And those quickly spread, give you peritoneal disease and all that stuff. That is like one end of the spectrum where you might not even see an ovarian tumor. But then there's also like all the serous epithelial neoplasms, including like serous adenomas that actually can be quite large, but actually quite benign. Does that make sense? So I think like what you're saying is right, that you can sometimes get them together and sometimes the like ovarian thing is secondary to it, but you can also just get like these big cystic tumors of your ovaries, and those aren't the ovarian cancers that kill you, but the ones that kill you are the ones that actually are these more aggressive ones arising from the fallopian tube.
Yes.
Yeah, cool. Okay, hold on.
I'm ready. So this is an elderly male in 70s, and should I tell you the history?
Prostate cancer,
Wait, is
pre-radiation.
it they did like a prostate
Gel. Yeah.
spacer infusion to separate the
But it's not in the right place. There's something wrong with it. Is it?
I can show you the MR also of this.
I think it's in the right place.
Go to the sagittal.
Sagittal of CT.
Yeah.
Okay, 1 second.
Like what is like on the right side? It's very strandy. Like there's some kind of
Like a little bit
interstitial.
is too.
Yeah, it doesn't. Oh. Yeah, like right there, it looks a little strandy. Like once maybe part of it is in the rectal wall. Yeah, do you have the MR?
I have the MR.
Ooh, it's really low too. See, right there. It's in the rectum.
But I will
right
say one thing. I showed some of my colleagues at UT Southwestern like about a rectal gel case that was in the wall, and they said that it doesn't matter.
Yeah,
It's not toxic to the wall as long as it's still like spacing out the prostate.
It's not
By the
so
way, is
much
that what this even is? Before we.
No,
Right.
this is actually not in the wall. This is.
But it's spacer gel, right?
It's spacer gel.
Okay.
So first things first. To begin with, when they started this used to be hypodense on CT, and now they've come with this second generation where it is hyperdense. So
Yeah.
we do not need MR to help localize. We can just take a CT non-contrast and we know if the spacer gel is in the right location or not.
Actually, and we read the pamphlet, like and they said this exact thing, which is that they added some like CT contrast agent to it to make it CT like more helpful to see it on CT.
Yes. The issue with this is it's asymmetric. And what do I mean by asymmetry is it should be bilateral symmetric. It's more on the right side.
But was the tumor on the right? I thought they had done it on purpose.
No.
No.
Usually because the way we irradiate is going to be like, sort of more homogeneous.
Circular, yeah.
So this is lacking on this side, and this for whatever I mean, most of these are outside imaging. For whatever reason, it was not on this side. It was known, but then they still went ahead with radiation. And I want to show you what happened after that.
Ooh, yeah. Perforation. That's exactly why our urologists don't do it. It's not the safety issue within like rectum. The problem is that it can injure the rectum, and then the patient has to be diverted, and just until the rectum heals.
Wow, this is crazy. Wait.
Yeah.
So do you think it's because it was in the wall or because it was asymmetric or what happened here?
Because the perforation is almost exactly at this side, like, if you want to imagine the gel was somewhere around here and the
Oh, so it was
perforation,
at the like thinnest part.
yeah.
So it was from the asymmetry, maybe.
Wait, no. So is it yours? What I don't understand. So it's not we I thought my understanding is we want it to be symmetric so that we're protecting the colon wall from radiation and
Yes.
later, radiation-induced proctitis.
Yeah.
Here, I don't think this is a radiation-induced injury. I think this is a technical injury. Or maybe the radiation kind
You're
of
saying
led to the
from the
from the
gel in the
interst
wall.
Yes, yeah.
I don't think there's any way we're going to prove it at this point, probably.
Okay. All right.
But both points are valid. That's
Hmm.
crazy. And then it, dissected into the thigh.
Okay. Sorry, to ask Dr. Tan, like you're saying it is more of technical, the perforation?
Yeah, so when it goes into the interstitium, like Aarti was saying, it's safe and you can radiate it.
Hmm.
The problem is that the wall, yeah, it's both, right? It's the actual gel is safe. That's not the issue. The issue
Hmm.
is when it does get radiated, there's injury and then patients get rectal perforation.
Okay. So the time difference between like the first CT I showed you and
Yeah.
this perforation is almost a year.
Oh, okay. So this is radiation-induced necrosis.
Hmm.
Wow.